is better than doing this procedure by fluoroscopic guidance. There are numerous different techniques available for the guidance during the percutaneous access. This is not only ultrasound and fluoroscopy, it is also the combination of ultrasound and fluoroscopy. It can be done on an endoscopic view, via laparoscopic approach, during a CT scan, by means of MRI, or with electromagnetic navigation. And there are also techniques described by means of a robotic approach and by means of augmented reality. The aims of the percutaneous access are a successful puncture of the renal calyceal system and to avoid any alteration of neighboring organs, such as bowel, vessels, or lung. And our aim is to minimize the bleeding and the radiation exposure for the surgeon. This is the renal anatomy, and as we heard several times today, it is advisable to do a percutaneous puncture through the papilla. The reason is that the anatomy of the kidney has a particular localization of the vessels, and if we are puncturing the papilla, the bleeding, the risk for bleeding is minimized. Now let us talk about the ultrasound-guided puncture. If we are doing ultrasound during puncturing the kidney, we have a continuous imaging of the internal organs in real time. This is what we really need. We can also call it something like an online CT scan. This is really an exact imaging of the internal organs during the procedure. We can add the so-called angiodynography, which allows us to have a simultaneous imaging of the vessels, which means we can clearly see where the bleeding may occur or not. Ultrasound has absolutely no radiation exposure, and it can be repeated at any time. And ultrasound is also cheap. It is cheaper to afford an ultrasound machine than an X-ray machine. Now let's have a look at different reports in the literature about the ultrasound guidance. This is a paper from 2013 evaluating the complication rate and grade in a percutaneous approach by means of an ultrasound guidance, and the results clearly show that there were almost no severe complications. Another paper coming from China from 2014 is a paper from Professor Li. Professor Li, I think, is the one urologist who makes the most totally X-ray PCNL procedures in the world. This is a very large series from about more than 8,000 patients, and you can see that he is very, very successful. Every puncture was successful, the stone-free rate was very good, and there were almost no severe complications. You should know that Professor Li is using a special disposable equipment for the ultrasound puncture. There are no plastic dilators, there are no metallic dilators. He is not using alkane dilators. He's doing the puncture under ultrasound guidance and then inserting a balloon catheter. And balloon dilation is possible to be monitored by ultrasound. I was astonished as I visited his department, but there is absolutely no X-ray facility in the whole operating theater. And the difficult thing was that I was also obliged to not to use any X-ray. Okay, there's another paper who compares ultrasound and fluoroscopic guided puncture, and according to the stone-free rate and the classification of the complications, there was no difference, but according to severe complications, namely the injury of a lung, fluoroscopic guided puncture was not so good. There's another paper comparing ultrasound guided puncture to fluoroscopic guided puncture. It is a patient number from almost 3,000 patients, a large number, and it's easy to summarize. Stone-free rate is the same, operative time is the same, hospital stay is the same, and the success rate is also the same. But the ultrasound patients had a shorter puncture time. It was a better success rate for the first puncture. The blood loss was better, and the transfusion rate was less. Of course, there were rare complications in the ultrasound group, but if you have a look at the fluoroscopic guided group, the number of patients where severe complications occurred was threefold higher. This also shows that ultrasound guided puncture in percutaneous stone surgery is superior. Now, what about the combination of ultrasound and fluoroscopic approach? This is another work consisting of 600 patients, and if you have a look at the complication rate and stone-free rate, this data is also really excellent. There was no angiographic embolization or nephrectomy needed. From my point of view, the recommended technique to puncture the kidney is a combination of ultrasound-guided puncture and fluoroscopic-guided dilation. From my point of view, the first step should be the insertion of a ureteral catheter, and then we have the possibility to apply a mixture of methylene blue and contrast dye in order to facilitate the puncture of the kidney. The next step could be the ultrasound-guided puncture. You can clearly see the dilated calyceal system, and the target area which should be punctured is clear. After that, a guide wire is inserted. And this is a point where a certain fluoroscopic guidance is recommended, because the next step is the dilation. I don't use balloon catheters because balloon catheters cause a higher risk of bleeding. I'm using a single-step dilation with a metallic dilator, a stainless steel dilator, and this cannot be done under ultrasound guidance. And finally, the unplugged sheath is placed, which means we have three parts of the puncture and dilation. The first part is the fluoroscopic part. This is the retrograde insertion of the ureteral catheter. The main part, which is the most difficult part, is the correct punction of the calyceal system. This is only done under ultrasound guidance. And the last part, which is very easy if you are sure that the puncture is correct, this is the dilation of the tract. In summary, this means that ultrasound guidance leads to a shorter puncture time, the success rate in ultrasound guidance is better, and complications are less. Therefore, there's no question, ultrasound guidance is strongly recommended for the puncture. The fluoroscopic guidance is easy to perform, and you get an imaging of the calyceal system, and the X-ray images are really excellent. Therefore, it is recommended for dilation. From my point of view, the combination of ultrasound puncture and fluoroscopic dilation should be the first option. Thank you for your attention.
Okay, so we have just very few time for a couple of questions, one or two. Are there any questions from the floor?
I'll ask Mr. Lahme for the learning curve. How many patients for the first of your experience to master this technique and whether you've been helped by radiologists at the first of your experience.
Yes, this is, I think, the main disadvantage of ultrasound guidance. This is the learning curve. For a German urologist, it's easy to answer this question because using the ultrasound in Germany for urologists is like asking about the weather or shaking hands. We do it frequently. This is our first attempt to any urological disease. Therefore, we are very familiar with all types of ultrasound examinations. This is a preposition to get a good result in the operating theater. If you have a certain basic experience in ultrasound examination, from my point of view, it is easy to learn ultrasound-guided puncture because the imagination of the three-dimensional anatomical structures is present and you clearly know how to puncture the kidney. I think the puncture should be done approximately 20 to 50 times under supervision of an experienced surgeon. After that, you have the basic experience to do an ultrasound-guided puncture, and then you have to enhance your experience, and this probably may need another 200 or 300 cases, to be honest. Yeah. But if you are not able to hit the calyceal system by ultrasound guidance, you can come back to the fluoroscopic guidance. And this is familiar to all of us. No problem.